Jai Shri Gurudev. In this video, we will see about hemolytic jaundice. Before that, we will learn about the definition, the classification of jaundice. The specific learning objectives of this session are definition of jaundice, classification of jaundice based on anatomical site and nature of bilirubin, and we will be discussing the causes, metabolic defect and characteristics of prehepatic or hemolytic jaundice with an example taking physiological neonatal jaundice. Jaundice is the yellowish discoloration of sclera, conjunctiva, skin and mucous membrane. This happens when serum bilirubin level exceeds 2 mg per deciliter, where it diffuses into tissues and stain them yellow. Any mere increase in serum bilirubin more than 1 mg per deciliter is called as hyperbilirubinemia, and this staining happens when it exceeds more than 2 milligrams per deciliter. Here we have to note that jaundice is not a disease by itself, but it is an underlying sign or symptom of an underlying disease. The causes of hyperbilirubinemia can be overproduction of bilirubin, or failure to conjugate and excrete bilirubin, or obstruction to the flow of bile. Now we will see the classification of jaundice based on anatomical site or clinical practice. So if there is any pathology before hepatic or liver, we call it as prehepatic, and the cause can be hemolytic, where there is increased unconjugated bilirubin, and Van den Bosch's test will be indirect positive. If the pathology is in hepatic or hepatocellular, there will be elevation of both types of jaundice, that both types of bilirubin, that is conjugated and unconjugated, and Van den Bosch's reaction will be biphasic. The third one is after hepatic, that is post hepatic or obstructive jaundice, where there is elevation of conjugated bilirubin, and Van den Bosch's test will be direct positive. In this session, we will just discuss mainly the hemolytic jaundice. So already we know in hemolytic or prehepatic jaundice, there will be increased hemolysis. The causes can be a genetic disease, for example, sickle cell anemia, spherocytosis, thalassemia, or a pyruvate kinase deficiency, an enzyme of glycolytic pathway, or G6PD deficiency, an enzyme of HMP shunt pathway. All this actually lead to the destruction of RBC membrane, thereby leading to increased production of unconjugated bilirubin. Apart from genetic, there are some infections like malaria, dengue, or it can be RH incompatibility in fetus, or ABO incompatibility during blood transfusion, or toxic induced like carbon tetrachloride, where there is increased hemolysis. Apart from that, very common is physiological jaundice of newborn. So we will discuss in detail about this physiological jaundice in later slides. So these are all the few causes where there is increased hemolysis, which lands up in increased unconjugated bilirubin and hemolytic jaundice. So as there is increased hemolysis, there is increased unconjugated bilirubin, which will come to the liver, where there is increased conjugation, and the conjugated bilirubin is secreted into the intestine, where it undergoes deconjugation and forms urobilinogen and stercobilinogen. So as there is increased excretion of stercobilinogen, there will be dark colored stools. And when we perform Van den Bosch's test, as there is increased unconjugated bilirubin, indirect positive will come. So even though there is increased bilirubin in blood, it is not excreted in urine because the type of bilirubin elevated is unconjugated, that is sparingly soluble or insoluble in water. That's why we don't get the bilirubin in urine in prehepatic or hemolytic jaundice. But the stool color will be very, very high due to urobilinogen, stercobilinogen. Coming to neonatal physiological jaundice. So We call it as physiological because this occurs in newborn infants after second day of life or within 1 week of life. So if it is a baby born with jaundice, we will put or categorize it as pathological jaundice. So physiological jaundice, usually the jaundice appears after 24 hours or 48 hours to 1 week. Here there is elevation of unconjugated bilirubin, and the normal reference range for an infant can be given up to 15 milligram per deciliter. So normally what happens, even though there is elevation in first week, it will come to normal by the end of second week. So the probable causes is there is increased hemolysis because there is conversion of HbF to HbA, which is coupled with immature hepatic system. Usually newborns, if they are premature, they will have intense jaundice. So because of premature hepatic system, there will be failure of uptake, conjugation and secretion. And also the UDP glucuronyl transferase, very important enzyme in conjugation reaction. The activity is little reduced in newborns. Coming to the treatment, it's just an exposure of baby to the sunlight or a phototherapy needed if it is very, very high. The bilirubin is if it is very high. So phototherapy is recommended if bilirubin goes beyond unconjugated bilirubin, total bilirubin goes beyond 20 milligram per deciliter. So in phototherapy, we use UV light to convert bilirubin to more water soluble isomers. So when infants are exposed to blue light in the range of 420 to 470 nanometer, there will be conversion of unconjugated bilirubin. The trans bilirubin is converted into cis bilirubin. So it is more water soluble when compared to trans bilirubin. So here there is no conversion of unconjugated to conjugate, but the form of trans is converted to cis, and cis bilirubin of unconjugated variety is more water soluble and it is excreted easily. So there is photooxidation of unconjugated bilirubin. Apart from this physiological, there are other few varieties of jaundice which are seen in infants, that is breast milk jaundice. This is actually late onset jaundice, somewhere seen in 6th to 14th, that is after 2 weeks of life. So breast milk has beta glucuronidase enzyme, and this enzyme causes deconjugation and enterohepatic circulation of bilirubin. And also the metabolite of progesterone, which inhibits the action of glucuronyl transferase. So because of these two causes, there will be little bit of jaundice seen in the second or after first week of neonatal period. So the treatment is temporary weaning of the baby from breast milk itself will get down this type of jaundice. Nitrous. So if unconjugated bilirubin exceeds the capacity of albumin to bind, that is, we have already seen in heme degradation, the unconjugated bilirubin binds to albumin for the transport in the circulation. So albumin has a capacity to bind this 20 to 25 milligram per deciliter of bilirubin. So if it crosses this capacity of albumin to bind, then as we know, unconjugated bilirubin is lipophilic. So it crosses blood-brain barrier and gets deposited in basal ganglion, hippocampus, cerebellum and medulla, etc., thereby causing mental retardation and toxic encephalopathy, which we put it as kernicterus. So sometimes what happens, the bilirubin can be normal, but drugs like penicillin, aspirin may precipitate this, where they dislodge the high affinity sites of albumin. So already we have learned that albumin has two affinity sites for binding of unconjugated bilirubin. So if that high affinity sites, from the high affinity sites, if the unconjugated bilirubin is dislodged, as it is lipophilic, it goes and stains the parts of brain, thereby causing kernicterus. So cautiously we should be using these drugs in neonatal period. Already they will be having a physiological jaundice, so that can be precipitated if we are using. So cautiously these penicillin aspirins should be used in neonatal period. Coming to the treatment, usually treated with phenobarbital, because phenobarbital induces the synthesis of UDP glucuronide transferase, an enzyme for conjugation of bilirubin. So with this, we have learnt in this session the definition of jaundice, classification of jaundice based on anatomical signs. Mainly, we have discussed about the causes, metabolic defect, and characteristic of prehepatic, and in depth of physiological neonatal jaundice. Thank you.